The Public Health Agency of Canada is partnering with CanVax to produce learning resources for healthcare providers on vaccines and vaccine confidence. We value your feedback and use information collected to inform us on future products. After viewing this video, please take 2 minutes to complete an evaluation survey. The link can be found in the description on YouTube and on the CanVax website. On to today's presentation. I'd like to welcome Dr. Natalia Abraham. Dr. Abraham is a public health and preventive medicine specialist and epidemiologist working in vaccine safety and surveillance at the Public Health Agency of Canada. She's a medical advisor for the NACI Secretariat and is co-lead for pregnancy and breastfeeding. Here are the objectives for today's presentation. Identify the risks associated with infection with SARS-CoV-2 during pregnancy, and explain the safety and effectiveness of mRNA vaccines in pregnancy and lactation, and for those intending to become pregnant. Over to you, Dr. Abraham.
Thanks, Stephanie. So these objectives are meant to build your knowledge of the evidence base that currently exists to support benefit risk discussions you have with your patients. So we'll start with the evidence that describes the unique vulnerability of the perinatal population to COVID-19 by looking at the increased risk they face when they contract SARS-CoV-2. What I present today is the most comprehensive data available on COVID cases in pregnant people in Canada to date. It is unpublished at the time of recording of this webinar. So Can COVID Preg is a national surveillance project that collected comprehensive information on outcomes for infected pregnant people and their newborns. It has data on 10,000 COVID-19 cases in pregnant women as of last month. However, there was almost no reporting from Saskatchewan, and reporting from Quebec ended in December 2020. Also, more recently, testing eligibility changes in the provinces and territories probably impacted detection. Nonetheless, you will see that the trends found in Canada mirror trends that are found internationally. Can COVID Preg took SARS-CoV-2 PCR positive case data from public health agencies and/or provincial databases by teams in each province. Their fifth report looked at data between March 1st and September 30th, 2021, where outcomes were collected on almost 7,000 cases. Hospitalization data was available on 4,700 people, and of these, 7% were hospitalized and 2.3% were admitted to the ICU or CCU. None had completed a primary series of vaccination. Can COVID found that compared to their non-pregnant counterparts, infected pregnant people were more than twice as likely to be hospitalized and more than 6 times as likely to be admitted to the ICU. It is thought that this increased risk may be due to the physiological and immunological changes during pregnancy, which increase susceptibility to more severe consequences of infection. These trends hold true for severe illness from influenza infection as well. Early data points to possible risk factors for severe outcomes, but the data is not strong. For hospitalization and ICU admission, being older than 35 years of age, having hypertension, and having a high BMI have been put forth as possible risk factors. The strongest risk factor found was being in your 3rd trimester. On the right-hand side, you will see that the rates of NICU admission and preterm birth were very high overall. 15% of babies born to infected mothers were admitted to the NICU, and 11.5% of babies born to infected mothers were preterm. A large living systematic review of 65,000 pregnant people up to October 2020 identifies similar risk factors as those found in the Canadian data. These include pre-existing diabetes, hypertension, advanced maternal age, and any pre-existing comorbidity. Similar estimates of the risk for severe outcomes of COVID-19 were found as well, where risk was at least twice as high for invasive ventilation, ICU admission, and ECMO. Here's another systematic review and meta-analysis. This one was published in the CMAJ in April 2021 and found data from around 440,000 pregnant people. These odds ratios show increased risk for preeclampsia, preterm birth, stillbirth, NICU admission, and ICU admission for those who became SARS-CoV-2 positive during pregnancy compared to those who were not infected. This review also looked at studies comparing outcomes in severe COVID versus mild COVID. While we can't make any more conclusions about causality here, it does appear that more severe COVID increases risk for low birth weight, C-section, NICU admission, preeclampsia, and preterm birth. There are a number of proposed pathophysiological pathways explaining these associations. In the case of preeclampsia, the vascular effects of SARS-CoV-2 infection may share a common pathway with the systemic endothelial dysfunction that is a hallmark of preeclampsia. The authors remark that SARS-CoV-2 infection may also cause exaggerated systemic inflammatory responses involved in the pathogenesis of preterm birth or a suboptimal environment for fetal growth and development. They also note that placental fetal vascular malperfusion has been found in placental histopathologic findings at delivery in COVID-positive patients, which could contribute to fetal growth, stillbirth, and preterm birth. So our key takeaways here are that the burden of COVID-19 infection during pregnancy in Canada is difficult to accurately capture with provincial, territorial, and federal surveillance systems. Pregnancy increases the risk of severe outcomes due to COVID-19, including ICU admission and the need for mechanical ventilation and ECMO. Risk factors for severe COVID-19 during pregnancy are common. People who are pregnant should be made aware of these risk factors to help inform their understanding of their own risk. COVID-19 during pregnancy is associated with adverse pregnancy outcomes, including preeclampsia, preterm birth, and stillbirth. And lastly, severe COVID-19 and pregnancy increases risk of adverse pregnancy outcomes. For the purposes of this webinar, I will cover immunogenicity, effectiveness, and safety data only for mRNA COVID-19 vaccines, as these are preferentially recommended by NACI in pregnant and lactating people. From what we can ascertain, it appears that pregnant people in Canada are less likely to be vaccinated while pregnant than their non-pregnant peers. As time passes, this gets harder to detect because once a person becomes pregnant, our systems can't distinguish between someone who got vaccinated before becoming pregnant and someone who was vaccinated while pregnant. So while earlier on in the vaccination campaign, we saw quite low estimates around the 50% range, we are now seeing that around 3/4 of pregnant people have received at least 2 doses. Comparatively, roughly 87% of all females in Canada aged 18 to 39 have received at least 2 doses. So there's a discrepancy there. Moving on, here's how we assess immunogenicity and effectiveness in pregnant people. As is customary, pregnant people were excluded from clinical trials. The data I will present on immunogenicity and effectiveness comes from research after COVID-19 vaccines hit the market. So prospective and retrospective cohort studies assess immunogenicity in vitro, looking at antibody titers, T-cell responses, and neutralization assays. Vaccine effectiveness studies generally rely on real-world evidence, whereas efficacy studies are randomized control trials. Test-negative designs are considered standard in testing for effectiveness for respiratory illnesses and pandemic settings. What has become clear as evidence has accumulated over the pandemic is that mRNA vaccines, mRNA COVID-19 vaccines work just as well in pregnant people as they do in non-pregnant people. They induce both oral and cellular immunity. And as is the case in non-pregnant people, antibody titers are higher in those who receive vaccine than they are in those who become infected with SARS-CoV-2. While we don't have any direct data on Omicron, we do have data showing that mRNA vaccines are very highly effective at preventing both infection, be it documented or symptomatic, and hospitalization. The level of effectiveness is comparable to the general population. And at this time, there's no reason to suspect that pregnant people would have a different response to booster doses than do non-pregnant people. However, we will have to wait for data to emerge on this issue. What we do know is that compared to wild type and other strains of SARS-CoV-2, vaccine effectiveness is lower for the Omicron variant for the general population. Nonetheless, protection is still quite strong against severe disease and hospitalization, particularly following a booster dose. One study by Collier et al. Comparing neutralizing antibodies in pregnant people and infant cord blood against the alpha and beta variant. They found reduced serum neutralizing antibodies, but importantly, cellular immunity appeared to be preserved. Parents often wonder whether getting vaccinated later in pregnancy or closer to birth provides better protection. In fact, there is evidence to suggest that antibodies crossing the placenta are higher in concentration with increasing time since vaccination. So the earlier the pregnant individual is vaccinated, the more antibodies are expected to cross the placenta. The research presented on this slide found this to be true, whether they were examining the first or the second dose. This figure hones in on the number of weeks elapsed since the second dose was received and finds a positive correlation over time, meaning that the placental transfer ratio is positively correlated with the number of weeks elapsed since the maternal dose, number 2. So while we have good evidence showing that antibodies cross the placenta, we know that the vaccine components do not cross the placenta. We have some early evidence suggesting that receiving at least 2 doses of vaccine during pregnancy helps protect infants 6 months and younger from being hospitalized because of COVID-19. This study by Halassa et al. Was published on February 15th, 2022 in the CDC's Morbidity and Mortality Weekly Report. It used a test-negative case control study design. So overall, they found 61% effectiveness, and this is thought to be an underestimate due to the Omicron variant during the last month of the study and the lack of accounting of booster doses received during pregnancy. The evidence base demonstrating vaccine-induced antibody transfer into breast milk is building. You may encounter patients who believe that breast milk might confer better protection than placental transfer, but this isn't likely to be true based on principles of passive immunization via placental transfer and persistence of antibodies in infants. At this time, we know that antibodies transfer into breast milk, but the degree of protection conferred to the infant is not known. One of the many benefits of breast milk are its inherent antiviral properties. So while antibodies are passed into breast milk, early evidence shows that SARS-CoV-2 virus is unlikely to be transmitted into human milk. We've provided here some key points that may help you when you stress the importance of vaccination when speaking with your patients who are either pregnant or planning to become pregnant. Most adverse outcomes occurring in pregnant people due to COVID-19 infection are in those who are unvaccinated or partially vaccinated against COVID-19. In fact, according to the recent Can't COVID Preg report, none of the 328 persons hospitalized with COVID-19 included in the study were fully vaccinated. All of the key advisory bodies relevant in Canada, so NACI, the SOGC, and the WHO, they all recommended immunization with COVID-19 vaccines at any time during pregnancy. And this includes booster doses because pregnant people are at high risk of severe outcomes. So our key takeaways regarding vaccine effectiveness are listed here on this slide. Immunogenicity and vaccine effectiveness are similar for pregnant and non-pregnant populations. However, most studies occurred before Omicron was the dominant strain. In the general population, the vaccine effectiveness against infection with Omicron variant is low, though protection against severe illness remains strong. Antibodies pass through the placenta and human milk following vaccination, although the degree of protection is unknown. Vaccination appears to be highly protective against hospitalization for pregnant individuals. Booster doses are important to increase protection against infection and severe disease. Now, I'd like to move on to the vaccine safety evidence for pregnant and breastfeeding people. There is a robust vaccine safety system in Canada that crosses many different sectors, from research and development to surveillance after the vaccine hits the market, known as post-market surveillance. This infographic is an overview of the system describing 6 major components. However, there is more to the story when considering pregnant populations, as I will deconstruct over the next few slides. I will go step by step through each of the 6 components on this infographic. So the first component is development. This describes the extensive safety and efficacy evaluations that occur in preclinical and clinical studies before any pharmaceutical product can be approved in Canada. In 2020, when companies were racing to get their COVID-19 vaccines on the market, the idea of phase 1, 2, and 3 trials became more generally known and discussed in the media. As a rule, the first sets of clinical trials exclude pregnant people. Nonetheless, sometimes there are a handful of people who unexpectedly become pregnant during large clinical trials, so sometimes we have a little bit of evidence to work with. Special animal studies are conducted as well to assess developmental and reproductive toxicology. So far, none have identified any concerns in animals vaccinated before or during gestation for any of the COVID-19 vaccines approved in Canada. Moving on to the second component, testing and approval, Health Canada conducts extensive reviews of the preclinical and clinical data to determine whether a product meets safety, efficacy, and quality standards. They have dedicated teams for preclinical evaluation and clinical evaluation. They even have their own researchers who can set up immunogenicity tests to verify them. The product monograph is a legal document. And that's produced by Health Canada in conjunction with the submitting manufacturer. So when there is no data on pregnancy other than perhaps the DART animal studies, you will find the product monograph contains typical statements such as this. The safety and efficacy of the vaccine in pregnant women have not yet been established. Animal studies do not indicate direct or indirect harmful effects with respect to pregnancy, embryo-fetal development, parturition, or postnatal development. It is unknown whether the vaccine is excreted in human milk. A risk to newborns and infants cannot be excluded. Perinatal healthcare providers at this stage can receive more direction from other guidance bodies to provide them with considerations they need for benefit-risk discussions. Canada's National Advisory Committee on Immunization, NACI, has a major role in providing recommendations on vaccine administration in pregnant and breastfeeding individuals. In the case of COVID-19, it became apparent early on that the risk of infection outweighed the known adverse event profile of mRNA vaccines and the theoretical risks from vaccination that may not yet have been detected. When the mRNA vaccines were first approved in December 2020, NACI guidance used language that the vaccine may be offered in the context of an informed consent discussion about limited evidence at the time. This language changed on May 28th, 2021 to a preferential recommendation that mRNA COVID-19 vaccines should be preferentially offered to those in authorized age groups. Provinces and territories take into consideration NACI guidance in their vaccine rollout planning, and they make decisions about where and when the vaccine become available. Healthcare providers are held to NACI guidance for standard of care. So here we come to the sixth component of vaccine safety, the monitoring component. As you can imagine, clinical trials can only be so large. The largest ones enroll tens of thousands of individuals and for a discrete amount of time. After the vaccine hits the market, post-market surveillance has the unique ability to detect rare adverse events that were too rare to be picked up in clinical trials. The other strength of post-market safety surveillance is its ability to detect events that might occur over a long period of time and in populations that were not included in pre-market clinical trials. There are a few different ways in which post-market surveillance is conducted. There are passive surveillance systems via mandatory reporting through public health systems. There is active surveillance. For example, in Canada, we have IMPACT, where most pediatric hospital records are continuously searched for adverse events following immunization. And there are numerous pregnancy registries and research studies on the go. Given all of these sources of evidence described and the hundreds of thousands of pregnant people vaccinated across the world in the last year, we now have a solid base of safety evidence that has been consistently showing that mRNA vaccines do not cause pregnancy complications or adversely affect human milk. What you can counsel your patients to expect are the same range of common side effects that the general population experience with mRNA vaccination. These include pain at the injection site, headache, redness and swelling at the injection site, muscle pain, chills. These side effects improve usually within a few days of vaccination. There are a handful of larger studies published that support these assertions. The European Medicines Agency conducted a detailed review of several studies involving 65,000 pregnancies at different stages, which they made public in January 2022, and they found no increased risk of pregnancy complications, miscarriages, preterm births, or fetal adverse effects. The CDC conducts studies on their VSafe Data, which is a smartphone-based tool that uses text messaging and web surveys to provide personalized health check-ins after one receives a COVID-19 vaccine. So as of February 14th, more than 201,000 participants have indicated that they were pregnant at the time they received COVID-19 vaccine, and over 16,000 are registered in their registry. This registry interviews participants during each trimester, postpartum, and during early infancy. They look at pregnancy outcomes like miscarriage and stillbirth, pregnancy complications like preeclampsia and gestational diabetes, and problems with newborns like preterm delivery, poor growth, or birth defects. They provided a snapshot of their results in September 2021 on over 35,000 pregnancies. The CDC has more data that they released in July 2020 from their Vaccine Safety Data Link, which is another system that examines health administrative data with controls on over 40,000 pregnancies. The CDC has a number of other post-market surveillance activities through their vaccine adverse events reporting system called VAERS, and they also have a clinical immunization safety assessment project and a birth defect study to evaluate pregnancy exposures. The UK also has published data on roughly 18,000 pregnancies using health administrative data with directly comparable and unvaccinated controls. There have been dozens and dozens of published case control and cohort studies from around the world that contribute to this evidence base as well. All of these studies, large and small, with a large variety of study designs, did not identify any increases in adverse pregnancy events above expected background rates at any point during pregnancy. Local and systemic reactions were examined as well as a wide range of the pregnancy complications like miscarriages and neonatal and other neonatal outcomes. There is a growing evidence base on safety outcomes in breastfeeding individuals as well, and it does not identify any serious effects on supply or on breastfed infants or children. There are several cohort studies that were designed to examine for any safety signals, and none were detected. A few studies identified a higher rate of local and systemic side effects in lactating people, which mirrors what occurs in the general population. These effects were minor and transient. So far, human breast milk tested at different time points after vaccination didn't have any detectable mRNA from COVID-19 vaccines. You may have patients who have concerns that vaccination may adversely affect fertility. There are preclinical, clinical, and post-market studies that provide emerging but consistent evidence that COVID-19 mRNAs have no impact on fertility. For example, they found no effect on anti-Müllerian hormone, which is a measure of ovarian reserve. No reduction in semen levels, and some studies on populations using assisted reproductive technology and in vitro fertilization studies, they found no difference in pregnancy rates, ectopic pregnancies, spontaneous miscarriages, intrauterine pregnancies, ovarian follicular function, and a number of fertilized embryos for IVF. On the other hand, infection with SARS-CoV-2 may reduce fertility in males transiently and for a minority actually in the longer term. Major professional and public health organizations agree that the alleged links between vaccines and infertility are unfounded and recommend vaccination for pregnant people and those intending to become pregnant. Related to fertility, there have been some concerns that mRNA vaccines can cause menstrual irregularities. Reports have been mostly anecdotal, and designing good studies to detect whether there is a safety signal here is difficult. Because most post-market surveillance systems are passive. They rely on reporting by healthcare providers who typically are not sought out by individuals experiencing non-serious, self-limited menstrual irregularities. And menstrual disorders are very common and can occur with a wide range of underlying medical conditions, as well as from stress and tiredness. Cases of menstrual irregularities have also been reported following COVID-19 infection. Transient menstrual changes are currently not thought to be associated with reduced fertility. There have been a couple of survey-based studies listed on this slide that have attempted to examine this issue, but the findings are very mild and of questionable significance. A recent development not captured on the slide is that on February 10th, 2022, the European Medicines Agency Pharmacovigilance Risk Assessment Committee announced that they are updating their assessment of reported cases of heavy menstrual bleeding and amenorrhea with mRNA COVID-19 vaccines with a new in-depth evaluation of all available data, including reports from spontaneous reporting systems, clinical trials, and the published literature. They state that at this stage, it is not yet clear whether there is a causal link between COVID-19 vaccines and reports of heavy periods or amenorrhea. They also stated that there is also no evidence to suggest that COVID-19 vaccines affect fertility. So our key vaccine safety takeaways are, because pregnant people were not included in clinical trials, post-market safety studies and surveillance are the primary means of assessing safety during pregnancy. Studies to date have found no safety concerns specific to pregnancy or lactation. There is no evidence that COVID-19 vaccines cause infertility. There is some evidence that vaccination may temporarily change menstrual cycle length by less than 1 day, which has no discernible clinical significance. Thank you very much for your time today.
For more of our webinars, please visit the following websites. A copy of this presentation will be made available on the CanVax website with clickable hyperlinks and a full list of references for the research used in this presentation. We'd love to know what you think. Please take 2 minutes to complete an evaluation survey. The link can be found in the description on YouTube and on the CanVax website. Thank you again for viewing.